Hi, everyone, and welcome to our 2 o'clock session. My name is Tina Costa. I'm one of the directors of the PHSA Office of Virtual Health. Continuing on this journey as your virtual host, my pleasure to welcome or re-welcome you to the BC Digital Health Forum of 2023. For those just joining in to our virtual circle, encourage you to share in our collective gratitude for the opportunity to come together from many traditional, ancestral, and unceded territories of BC First Nations. And let us continue to give thanks for the opportunity to gather, learn, collaborate, and provide care on these beautiful and sacred lands. I now get a great opportunity and pleasure of introducing our next presenter, Dr. Lori Brotto. Dr. Brotto is a renowned figure in the field of women's sexual health. As a professor in the UBC Department of Obstetrics and Gynaecology, she holds a Canada Research Chair focusing on developing safe, accessible treatments for prevalent sexual concerns in women. Please join me in welcoming Dr. Brotto on her talk entitled here, Virtual Reality is Potential Treatment for Individuals with Vaginal Insertion Phobia. Dr. Brotto, over to you.
Thank you so much, Tina, and hello, everyone. And I too would like to extend my gratitude for being able to come to you today from the traditional, ancestral, and unceded lands of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And so, as always, give great gratitude for being able to live on these stewarded lands. So I hold a Canada Research Chair in Women's Sexual Health, which means that I do spend the majority of my research time trying to understand the causes of and treatments of sexual difficulties, mostly in women, though also in gender diverse and in individuals and men. But for today's presentation, I'm really going to focus on some of our more recent research, which is focused on female individuals. I will at the outset like to give credit to my amazing PhD student, Natalie Brown, who has really been the steward behind all of this work. And so thanks, Natalie, from the outset. So the topic today is focused on whether we can take virtual reality, which we often think about in the video games landscape, but increasingly over the last decade, or if not more, has really made an inroad into a potential treatment for other common anxiety disorders that require really exposure. And so in this study, what we decided to do was to really develop a proof of concept about whether virtual reality might be a tool that we can use with a particular sexual condition that we call vaginismus. So vaginismus is categorized as a sexual dysfunction. It's characterized by an extreme fear or anxiety of vaginal insertion. So this would be the person who has tremendous fear of having a speculum exam in the context of cervical cancer screening. They avoid tampons for menstruation. They would totally avoid or endure with very significant anxiety other kinds of sexual vaginal insertion. And it's really characterized, in addition to the fear, by this involuntary tightening of the pelvic floor muscles. Now, the pelvic floor muscles, for those of you who are not quite sure what they do, they serve a very important function in terms of keeping organs where they need to be, supporting the bladder, supporting the uterus in people who are assigned female at birth. And when the pelvic floor muscles are too loose, then we would see symptoms like incontinence, which is the involuntary leakage of urine. When the pelvic floor muscle, on the other hand, is too tight, this essentially can feel like there's a wall closing off the opening to the vagina. So oftentimes these women will say, it feels like I'm hitting a wall when I'm attempting to insert a tampon or attempting sexual activity. And it's because it really is like a wall. So that small opening in the pelvic floor, when the pelvic floor muscles are tight, essentially closes off that opening. And if you can imagine putting yourself in this situation, they would have tremendous difficulties with sexual activities that involve vaginal penetration, cervical cancer screening in the context of pap smears, greatly hampered. These are women who avoid altogether pap screening, and also using of a tampon. And so it's not unheard of that we often hear women with vaginismus will say that they've undergone, many, many years of their life, or if not decades, of completely avoiding these activities. So why virtual reality treatment? Well, first of all, as someone who does a lot of research into sexual health treatments, and also as a registered psychologist who delivers sex therapy to people, I can say that there are a lot of barriers that people face in general. Sexual health is still an area that's laden with taboos and stereotypes and shame and secrecy. And so even when we look at the available treatments for vaginismus, those colored things that you see on the slide there, those are vaginal inserts. And so gold standard treatment for vaginismus entails asking the patient to take these vaginal inserts, to go home, and slowly and progressively, starting with the smallest one, to insert it into their vagina, and combine it with relaxation. So the idea is that if the person can relax their mind and therefore relax their body, and given that they are operating the insertive device themselves by slowly moving the dilator in or insert in, that maybe this will help them overcome some of the fear that's in place. So all of this makes sense in theory. And as I said, this is considered gold standard treatment. The problem is that because anxiety and fear are so high for these patients, there's a lot of avoidance behavior. So they'll leave your office with every best of intention to go home and use the inserts, and then they'll go home and be stricken with fear that they're simply unable to practice. The other challenge with these inserts is even for those individuals who are able to progress through the inserts, oftentimes when there's that transition from working through the vaginal inserts to then transitioning to sexual activity with the partner, there can be a huge surge of anxiety again. So again, stemming from the belief that, well, with the vaginal insert, I'm in control, I'm controlling the depth and speed, et cetera. Whereas in the context of partnered sex, the person really feels like they have no control over insertion in that situation. So again, anxiety can spike. So why virtual reality? Well, we know a little bit about virtual reality exposure. First of all, virtual reality exposure, or VRE, has been tested, has been found to be feasible and even effective in the treatment for phobias. So as one example, a very common phobia is flying phobia. So those individuals, if you've ever sat in an airplane and they're sitting beside you and they're gripping the armrest and their eyes are closed and their beads of sweat dripping from their face. And these are people who are panicking while flying. Why? Because of fears and beliefs that the plane will crash, I will die, I won't see my family again. And as uncommon as that is, there is still a teeny tiny proportion of chance that can happen. And that chance of likelihood is enough to keep that fear going. So if you can imagine what typical exposure therapy would be to have that person in the airplane, up in the air, and then have someone like me, a psychologist, train them in progressive muscle relaxation, help challenge their fears, and essentially bring them back to a place of relaxation. Not very feasible, not to mention quite expensive. So here is where virtual reality exposure, where the person can put the virtual reality unit on their face and through a simulation actually see themselves getting in the airplane, putting on the seat buckle, taking off, and then while the person is beside them, can teach them these relaxation strategies. So much more feasible, very effective, much lower cost, and has been found to be really quite effective for overcoming some of these. So the idea is that through this virtual reality environment, which is 3D, three-dimensional and immersive, in the very feared situation that they are avoiding. And that's kind of the essence in VRE. So when we look at vaginismus, although it's categorized as a sexual dysfunction, it really has a lot of similarities to traditional phobias. There's the marked anxiety, there's the sympathetic nervous system response, there's the unrealistic beliefs, such as really quite vivid beliefs about the dangers of vaginal penetration, et cetera, et cetera. And many of us have argued for years that it probably would be better classified formally as a specific phobia or anxiety disorder and not a sexual dysfunction. So the advantage of taking a virtual reality environment and bringing it to vaginismus is, number one, we can manipulate that sexual environment for them without the need for a partner, without the need for vaginal inserts, and it can be done entirely in a controlled setting. So that's kind of the background rationale of VRE for vaginismus. So we undertook a proof of concept study where we wanted to determine whether virtual reality sexual scenes could elicit enough fear that it has all the makings of being able to be a virtual reality exposure. So it was really about, can we elicit the same quality of and intensity of fear as the person reports when they're at home in their real life environment? Secondly, given that this was really the first time anyone had attempted to use virtual reality as a potential treatment for vaginismus, we were interested in what are the features of the stimuli that would increase or decrease the person's sense of immersion and presence. So the things that we manipulated would be point of view. So first person point of view would be imagining, sort of seeing the scene as if it were really happening. Whereas third person point of view would be, they sort of look like they're sitting on, some distance from the actors in the scene. And then we also manipulated the kind of intensity of the sexual scene. So some scenes depicting vaginal intercourse and some scenes that were depicting sexual scenes that did not involve penetration. So oral sex that did not involve penetration. And then we also followed this up with some fairly in-depth interviews, since this was a proof of concept study with the goal of eventually maybe integrating this into a treatment. We were very interested in the participants' firsthand experience. How acceptable was this? What kinds of psychoeducation do they think we would need to add in order to really make it a plausible treatment that they could receive in, say, a clinic setting? So the specific research questions we asked, we wanted to determine whether virtual reality sexual scenes elicited enough fear, the features, and in order to do that, we compared 40 individuals who were diagnosed with vaginismus, and we had a wonderful gynecologist on the team, Dr. Melanie Altus, who confirmed the diagnosis of vaginismus and ruled out other explanations like a pain disorder. And then we compared them to a control group that did not have vaginismus. And as I mentioned, the sort of features of the stimuli that we manipulated was the point of view. First person feels very much like you are an actor in the sexual scene. And then third person point of view is as if you were watching it from a distance. And then secondly, manipulating the kind of intensity of the scene, one that involves vaginal insertion and one that does not. So interestingly, we had no difficulties recruiting for this study. My hunch is that given how prevalent vaginismus is and how difficult it is to, first of all, find treatment, and also, again, many of the fears and anxieties that people have, they were very motivated to participate in this study. So recruitment happened very quickly. We're quite happy with that. You can just see here on the screen some of the criteria that we included. So although we did require that participants were assigned female at birth, in other words, they endorsed a sex of female, they could have any gender. So they may have identified as a cisgender woman, they may have identified as a non-binary person, an agender person, etc. And that you can see the criteria there for vaginismus. So fear of insertion combined with that intense pelvic floor tightness, along with significant distress. And this had to be a lasting condition. And we ruled out anyone that had simultaneous pain. Where do we advertise? Social media, bus ads. Actually, our bus ads do really well in the Lower Mainland. and then also traditional postings everywhere. In an effort to try and offer appropriate compensation for people living in more remote communities of the province, and also in an effort to recruit a more diverse sample, we offered additional funding for those people to support those who really had to travel a very long distance to come to us. So thank you to our granting agency for, that was VCHRI who provided the funds to do that. So what did they do? They first had a phone screen to verify their interest and preliminary, they had a preliminary description of the study. They then underwent a physical exam with our gynecologist, Dr. Altus. They then came into a controlled, internally locked room in our research environment in the UBC Sexual Health Research Lab, where they placed the VR unit on after having some training through Natalie, my PhD student. In the VR headset, they viewed all of the stimuli and they completed all of the questionnaires with the headset on. So there's a remote that allows them to select the answers to the questions without moving the VR headset on or off. They also were reclined in a very comfortable sofa chair as well. When the session was over, they removed the equipment and they took part in an interview with someone who was not involved in the experimental testing. So you can just see here, this is everything I've just described. So when they watched the film, they would see different, the different film conditions were counterbalanced. So they would have third-person point of view with oral sex, third-person point of view with intercourse, first-person point of view with manual stimulation, first-person point of view with oral, and first-person point of view with intercourse. Thank you to the interpreter for catching all of that. But visually, you can sort of see what they experienced there. And then these were control films. So these are waves. We had a nice neutral video in between the erotic stimuli just to give them a break, especially if they were feeling anxious. And we asked them to measure their subjective units of this distress. And this is really considered gold standard way of measuring distress from 0 to 100. How much personal distress are you feeling? And this is essentially the subjective unit that is also used in characterizing vaginismus. Little bit about who participated. The mean age was 28. You can see about half were opposite sex attracted, but a nice diversity in the sexual orientations, some diversity in gender as well, although keep in mind, all of them were assigned female at birth. Some good racial diversity in the sample as well. And again, we want to thank our ability to fund people, which is kind of maybe a side take-home message is to make sure that your compensation is appropriate. And 60% had never been exposed to VR before. So here we get to the results. So when watching the films, were there parts that made you feel anxious, fearful, or distressed? Keep in mind, this is our primary outcome. We want to create some fear in order for this to be a potentially conducive VR exposure. So in the vaginismus group, as predicted, 3/4 said, yes, I felt anxious, fearful, and distressed, whereas less than 1/4 of the control group said that. When we look specifically at the group differences, and so these are the different slices of time, still on that subjective units of distress scale. So the difference between the control and vaginismus, you can see even at baseline, before seeing the films, the vaginismus sample was had significantly more distress, but that was amplified. These are very large effect size. A Cohen-D of 1.0 is a large effect size showing those group differences. So the control group had no increase in distress after the film, whereas the vaginismus group did. And then you can see the change there that takes into account their baseline differences. We also looked at safety behaviors. So did they do anything during the testing as a way of avoiding? And you'll remember I said earlier that despite the fact that vaginal inserts is gold standard treatment, many of them will avoid them when they go home. They simply won't do the homework. So the control group, less than 1/4, said that, yes, they engaged in some safety behavior, kind of looking away, maybe closing their eyes, whereas 3/4 of those in the vaginismus group did. There we go. Oh, imagine myself somewhere else as well. Okay. Now, I think this is the last data slide I'm going to show, but this is really about what are the features of the film, because if we're then going to move on and actually use this in a clinical intervention study, we need to settle on one particular stimuli of film. And what we found is that really it didn't make that much of a difference whether they were watching third person point of view or first person point of view. And also whether it was oral sex or penetrative intercourse. You might say that this difference here was the largest. These two differences collectively were the largest with the intercourse scenes, but really there were no significant differences. So one of the conclusions we make from this is that the virtual environment is effective for eliciting distress, even regardless of the specific features of the sexual film. So when we do this in our next study, we're going to select a single film to show participants. We're still in the middle of analyzing all the in-depth interviews, but I can say that what the 40 participants with vaginismus have shared with us so far is that they could see themselves represented in the kind of design of the study, but also in watching the film. It elicited distress that was very equivalent to what they experience at home. They said that they would like to have some choice in selecting the stimuli. Maybe they have the option to actually choose their partner and have their partner show up in the VR unit. So one of the studies we're doing right now is experimenting with different kinds of avatars that more closely mimic the person's partner. That might also include being able to vary skin tones, body sizes, etc., to make features more similar to the person's own partner, and in turn, therefore make it more real-like. And they've said that even just participating in this study give them that sense of community, feeling like they're not alone. Again, this is a condition that can be highly embarrassing, taboo, difficult to talk to a family doctor about. So they were so thrilled that that the team was really choosing to focus on this area with the goal of developing a treatment that could be very accessible for them. So we were really lucky this year to receive a CIHR project grant, and this is the next study that we're doing. We're not doing a randomized clinical trial. We are using a single case design where the person with vaginismus serves as their own control. And what you manipulate is the amount of time they spend in the control condition versus the virtual reality condition. That's kind of the experimental agent in this. And so every person really serves as their own control. Can be a very powerful way of determining cause and effect and efficacy that overcomes some of the real challenges in RCTs. So really excited to be able to do this, and we'll be bringing on a postdoc to lead this middle of next year. So with that, just really want to thank the team again, Natalie Brown, who's the champion of this work, amazing PhD student, my collaborator in the Department of Psychology, Dr. Alan Kingstone, Dr. Altis, a gynecologist, and our team statistician, Dr. Stadniak. And happy to take any questions now.
Thank you so much, Dr. Brotto, for your advocacy in women's health, but also demonstrating how we can use these digital health tools to support particularly individuals that face stigma in healthcare. We saw a presentation, I think it was on Tuesday, around using VRE as a supportive tool for individuals with mental health or substance use issues as well. So thank you for that. You mentioned the acceptability of VRE as a component to success. And it sounds your participants seemed quite motivated, which is great, but I wondered if just the introduction of VR technology created additional anxiety to your participants, and if you could speak to that.
Yeah, it sure did, Tina. And, you know, Natalie, who is the person at the door who welcomed them and explained all the procedures, we really worked hard to keep everything consistent. So the person who spoke to them at the beginning and the person they saw and the person who did the testing was all the same person. Natalie's also training as a clinical psychologist and really created a safe and comfortable environment. We reassured participants that they were in an internally locked room, that it was soundproof. And so that was really critical because again, I don't know if anyone in the audience has ever experienced anxiety or even a panic attack. Even just the thinking about sexual activity for persons with vaginismus is sufficient for eliciting very high levels of anxiety and even panic. And so really important that we create an environment where they feel safe, but even more importantly, where they feel in control. So we would say things like, you can take off the headset anytime you want, you can discontinue and leave anytime you want. And that really went a long way to actually helping them stay and feel more committed to the project.
Oh, great learning for anyone interested in that. Thank you. I really appreciate that answer. It was a definite curiosity. So we don't have any other questions, but there are lots of emotions coming up from the broad, lots of claps. Thank you so much for your time and for joining the forum, Dr. Brotto. We will close this session. And so you'll see, the audience will see a Zoom poll come up. That's great. And we will invite people to our next session, which I believe might be the just about second to last session of the day. So, which is my guide, Long COVID, Achieving Better Health Through Caring, Leading, and Learning Together. Thank you again, Dr. Brotto. Appreciate your time.
Thanks, everyone.